Hi, and welcome to the Dr. Coffee Podcast, your weekly blend of motivation, encouragement, inspiration, and insights into all things medicine for junior doctors and medical students in South Africa. Welcome to episode 14. In this week's episode, I had a coffee and a chat with Dr. Johann Lamprecht, an ophthalmologist in private practice in Rosebank, Johannesburg. I first met Dr. Lamprecht when he was an intern at Charlotte Maxeke, and I've been friends with him for about 15 years now. I hope you enjoy our conversation about his path in medicine and what it takes to specialize in ophthalmology. Without any further ado, here is Dr. Lamprecht. Welcome to the Dr. Coffee Podcast, Dr. Johann Lamprecht. So good to have you on the show.
Thank you, Simon. It's great to be here.
Thank you so much for giving us so much of your time. And with all my guests, the first question that I ask is where you graduated from medical school, when, and also where you did your junior doctor years. So that would be internship and community service.
All right, so I did undergrad in the Free State, UFS, qualified in 2007, and then I got my internship post at CMJH, and did 2 years of internship there, and then I did my houseman year at the old Natalspruit Hospital in Katlehong, and then I specialized here in Joburg.
Okay, so tell us about your specialization, right? So after doing community service, you did some MO time, or was a registrar post available for you right away?
No, so that, in ophthalmology especially, that I guess it never happens. Maybe it has on occasion, but I had to do 1 year of MO time, which is actually considered quite little.
Okay.
I did my internship and then made contact with the department and started attending the academic meetings because I knew what I wanted to do. And then I started attending the academic meetings during my houseman year on my Fridays that I finished early. And then I got the MO post straight after that, which was very fortunate. A lot of people actually have to go and work in different hospitals with smaller eye departments to get experience before they even get an MO post.
Wow.
So I got the MO post, and also based on the availability of other MOs and people's interest during that year, I often call it the hand of God, because there were so many people that came and they were just like, nah, this is not for me. So I was the only MO at the end of that year that had my exams that I needed and had surgical experience and so forth.
Wow.
And that was already in the department, that by the time the interviews came around, then the reg post was available. So it was extremely fortuitous. I spent 1 year of MO time. Sorry,
Sure.
Long answer for a short question.
No, that's great.
It was a very interesting, just how things just fell into place, and even at an institution like Baragwanath or St. John Hospital, where I did my MO time, there's obviously a lot of administrative work as well. So medical officers might have a huge burden and not do as much surgery as they do in a place like, for instance, Kimberley or Swaziland or one of those places. But because I was the only MO and they needed assistance in theatre specifically, I also got a lot of surgical experience.
Wow.
During that 1 MO year, which was extremely valuable. So I'm very grateful for that.
So a busy year,
Yeah.
but it sounds like, first of all, you mentioned you knew from the get-go ophthalmology is what you wanted to do. And it sounds like you also chased the opportunities. You said that when there were gaps, you went to academic meetings, and when people weren't seeing that it was for them, you took up the slack and you said, like, I really want this. So 1 year is short for MO time. Roughly, what's the ballpark figure somebody can expect to be an MO in ophthalmology?
I would say probably a year before the MO time, and then about 3 years of MO time.
Okay.
And then your reg time, which is around 4 or 5 years.
Okay, so you obviously had applied for an MO post.
Yes.
Was that MO post specifically at St. John's Eye Hospital?
Yes.
And that MO post, you would have seen an advert and you said, like, this is where I want to be. Had you worked at St. John's Eye Hospital before?
No.
So this was a completely new experience, but you knew that ophthalmology was for you. Maybe there's some people who are listening to this podcast or watching the video, and they are considering ophthalmology.
Yes.
What was it for you that helped you decide ophthalmology is where I want to be?
So that's a really interesting question, and I often get it, and I don't have my first answer is always, I'm sorry, I don't have a really cool answer, because I don't. It's just all I've ever wanted to do. I knew before I even finished school that it's what I wanted to do, and I didn't know ophthalmologists, or there aren't any other doctors in my family, or at least not in my close family, and it was just, I think it's a speciality that sort of found me, and it makes sense now in retrospect, but I can't really explain in detail how the journey went. But it's this combination between every system in the body affects your eyes, and you can see signs of all the common conditions also presenting in the eye, and at the same time it's a very, very narrowed down specialized approach, and it includes microsurgery. So it's this really comprehensive knowledge of medicine, but then when it comes to your part in the team effort, you don't have to do all the biologics and all the repeat special investigations in terms of like central nervous system imaging and the blood tests and all of that. You work with physicians and neurologists and neurosurgeons and so forth, and when it comes to your bit of treatment, it's very cool in the way that it's extremely technology driven, microsurgery, 3D
There's nice toys.
systems. Exactly. We're very toy dependent, and unfortunately, that's a whole different side of the practice, which you might get to if we have time. But economic factors that determine how much it costs to actually have an ophthalmology practice, and the exchange rates and so forth, that has an impact on what it takes to stay up to date as an ophthalmologist and have the latest equipment available, and how then do you provide that service to your patients and make it still financially sustainable. That's another side of the discussion, but that's what, looking back, I find very attractive about ophthalmology, is those different aspects. You don't just throw medicine out the door, but at the same time, your treatment modalities are very focused, and you get to be a very niche part of the whole treatment team.
I understand. So the common path to ophthalmology will always be some MO time, and then applying for a registrar post in ophthalmology. That will last, you said, 4 years. Is that 4 years across the board, whether you do it here in Gauteng or in the Western Cape? It's 4 years standardized.
Yes. There's a little bit of flexibility in that, depending on the amount of experience you have. But the College of Medicine of South Africa, Colleges of Medicine of South Africa have certain requirements in terms of time you need to spend in clinics, getting experience, surgical cases, and there are different steps that you need to go through before you can advance to the next examination. So some people would have a lot of experience and come in as a registrar. They might apply to get 6 months off their registrar time.
Okay.
Or other people might have been pregnant during their reg time and might apply for 6 months extension to finish their exams, and so on and so forth. Yeah.
So the 4 years, within that time, you have to have completed certain tasks, certain exams. What are the primaries like, or what exams are there for ophthalmology?
So it's primaries, intermediates, and then your part 2, your finals.
And are those surgical primaries, or is it specifically ophthalmology?
Specifically ophthalmology. So your the exams changed quite recently. So during my reg time, more or less, I think the first new set of exams, it used to be primaries and finals. And then they broke up the anatomy portion of that and brought part 1B in, which was much more in-depth focus on your pathology and your intraocular tumors, and so they just extended the scope, expanded the scope a little bit of that exam and divided it into 2. And now the demand for ophthalmology posts is so high that most MOs actually finish part 1B, their second exam, and then you go into your reg time having to only do your research master's degree and your finals. So there's 3 exams. They all have their sort of ups and downs, but the part 1 is now less difficult, I think, than what it was. The part 1B is, I think, more difficult than what that portion of the part 1 used to be, because there's more of a focus, and you get back to the microbiology and the pharmacology and all of that in much greater detail, because it now has its exam on its own. And then also the optics. Optics used to be sort of divided between part 1 and part 2, whereas now there's a very specific focus on the optics, the refraction, and because it becomes more and more complex and incorporated in our different imaging systems and the special investigations we do. So there's a bit more of a focus on that as well. The increased use of different types of laser technologies and so forth. So
wow.
yeah,
So it's more a case of just modernizing and updating
exactly
the training process,
yes.
rather than trying to make it more difficult, or
Yeah,
there was no sinister motive, let's say.
Absolutely not. I think it makes perfect sense actually.
Yes.
And it gives you an opportunity in future. I don't think it's optimized in that way yet, but it gives you an opportunity to start choosing the path that you are likely going to follow as an ophthalmologist, because all medical specialities are becoming more and more sub-specialized. And there are countries in which there are strictly medical ophthalmologists or neuro-ophthalmologists or pediatric ophthalmologists. So having these exams that really test where your strengths lie, you obviously need to have comprehensive knowledge, but I think it helps you to steer you as the candidate in the directions of interest and strengths. And once you've qualified, then you have a better idea of where you fit in the system.
That's very good. So as medical students, we don't get much exposure to ophthalmology. I think at WITS we got 2 weeks in our 5th year of ophthalmology. How would somebody need to characterize their interest in ophthalmology if that's really something for them? What are some of the key words or key things that you think a good student of ophthalmology should have within them? What traits should they have?
That is an interesting question, because we are diverse even as ophthalmologists. But having said that, and I think most interns specifically that have this slightly higher turnover of different specialities that they go through, and you get a better idea of the vibe within each subgroup. And there definitely are personality types and just certain sort of personas that fit within each. Ophthalmology has that need for perfection. We're sort of friendly type A's, if I can put it that way. We can all immediately think of the type A specialities out there in medicine, and then ophthalmology seems to be on the surface a little bit of less loud a personality, but deep down there's this incredible drive for a high efficiency and at the same time maintaining that perfection. We often see patients with 20/20 vision, but they're not happy with their vision. So you need to really be able to interrogate those finer nuances, the subjective aspects of vision, and that it requires patience, but at the same time it needs to be managed very carefully, because you can't, it's not for instance a psychiatry or a psychology consultation. You have to get down to what is practically going to help the patient. So you constantly have to manage that tension. And then, like I said, there has to be an awareness of what's happening in the whole body, because it's those things that present as eye conditions. And we often diagnose multi-system conditions, often life-threatening conditions. Think of things like CMV, retinitis. Patients present having absolutely no idea that they are HIV positive and have CD4 count of 40, and they come in, the first sign is they went blind in an eye, and you look in there and the retina is completely necrosed, and now you have to go and start this whole journey with this patient, while at the same time they have an emergency eye condition that you need to treat, and they need to process all of this quickly. You don't want to lose them, because people just get freaked out and overwhelmed. So how do you link them up to their infectious diseases specialist and the psychological counseling that they need, and you need to have an idea of what the other investigations are that they would need to immediately assess their risk. And the same goes for TB, the same goes for multi-system inflammatory conditions like lupus, and obviously diabetic eye disease we all know about. So huge communicable and non-communicable disease profiles within the eye that often presents in the eye. And then you have to like I said, we become part of a much bigger team with a very focused management, but we often see the patient first. And you need to know, you can't just go, oh, you have uveitis, inflammation in your eye, and let's give you some steroids and see if you get better. You need to go, well, what kind of uveitis is this? Is it likely infectious? or non-infectious, and what is the extent of it, and who do we need to refer you first, because this can also be a life-threatening condition.
So to summarize your answer in a way, if somebody is interested in ophthalmology, they need to be aware that it's not just focusing only on the eyeballs and leaving, as Dr. Glockenflecken calls it, body medicine alone.
Yes, real medicine.
All of that is still a part of your daily experience in your daily practice.
Absolutely.
And your medical training, you don't say, okay, well, 7/8 of my medical training doesn't count anymore. It's all still a factor in your management of patients.
So it's interesting. I really, really did not enjoy medicine until I became an ophthalmologist. And that's why I think that personality is that person that wants to focus on something, and they have high demands and perfection of themselves, and you can't do everything perfectly. So you have that wide scope of knowledge, but then you yourself want to work in a narrower scope and really aim for those perfect results and create more and more of a niche until you feel like you're the best doctor that you can be.
Yes.
I would be a horrible GP. I would be a horrible pediatrician. I would be horrible orthopod. Maybe I almost did orthopedics, but so. Did
you know that before becoming an ophthalmologist?
Yes.
Okay.
Unfortunately, so medicine. There were these papers that we just go like, I have to pass this, but like I really just have to pass this so that I can one day become an ophthalmologist. This is, and then granted, you look back and you go, okay, actually, I needed all of this knowledge.
Sure.
I needed all of this to be the best ophthalmologist that I can be. So, it just comes back to the question, what sort of person, what are the things that stand out? I think it's a person that's driven for perfection, and they know early on what they want, and are willing to go to slog through all these processes, like the long time it takes to get into ophthalmology. And, then all of a sudden it's like you just start over. You have this very steep learning curve on procedures that you've never done before, on instruments that you've never worked before. It's not the same sutures, it's not the same gauges, it's not the same viewing systems. Everything's new, you just have to start over. But you have that single-minded focus to get, into a speciality where then you have these extremely high demands in terms of efficiency and visual quality, and all the while not forgetting, like you said, throwing the other 70% of medicine. And it's so interesting, the psychology even of it. 75% of people regard losing their vision as the worst physical loss they can suffer, including limbs, including memory, and then obviously the other senses like smell, taste, etc. So we see a lot of anxiety around visual symptoms, and conditions that present with visual symptoms, which are sometimes just common migraine, and sometimes raised intracranial pressure, which people are oblivious to, but they have these dimming vision symptoms, and they often just present with the anxiety of going blind, and then you have to deal with that based on how serious or not it is, and often people just want to hear the words at the end, so you're not going blind. If they don't hear that, everything else was a complete waste of time.
Yeah.
So there's even a psychology that you can't ignore in terms of addressing the needs of the patient. So very, very interesting, very focused, but at the same time so wide in how you have to approach the patient, which I guess is all of medicine has gotten to that point where we realize, it's holistic medicine. And I think that's why you have this constant tension between people becoming more and more super specialized, while at the same time you realize you have to practice holistic medicine. You have to consider all the other aspects of the being in front of you, and somehow incorporate it into your treatment paradigm.
So you've mentioned a couple of times how competitive the road into ophthalmology is, and especially for our junior doctors listening that are considering their career options on the other side of internship and ComServe. What do you think, let's just interrogate that for a second, what do you think is driving that competition for places? Are there just not enough posts to fulfill the actual need for ophthalmologists in South Africa? Or what is it that's appealing to people that makes them consider ophthalmology as a career?
That's a very interesting question, and I haven't actually thought about it. I was just all about get in, and perhaps one should look at this at a policy level. It would definitely have historical factors, economic, political, etc. And ophthalmology is kind of seen as the eye is that small little organ there. Like, why is it so important, and why is your equipment so expensive, and why are your procedures so expensive? And it's sort of relegated to the side, I think, perhaps on a policy making or a decision making and a budget allocation level, while at the same time there's such a need for it because of the severity of visual disability.
Sure, and what you said about how 75% of patients would consider losing vision more serious than losing a foot or an arm or a leg.
Exactly, and there are studies that show that, roughly it roughly halves your mortality and your morbidity per age before and after something like cataract surgery, simply because you've got a lower risk of car accidents, falls, taking the wrong medicine, misreading labels, and so on and so forth. Like, just improving your vision improves your all-cause morbidity and mortality, per age of the individual. So it's that important but high cost, niche speciality, and with a specific individual that goes for it, and then at the same time you have to fit that into the greater scope of medicine, and you've got the huge burdens of your overall systemic non-communicable diseases, so they need physicians, and I think that's where that tension lies, and ultimately something's got to give.
And also, of course, all the training posts are funded by a public health system that has to allocate resources. Exactly. And like you said, people think, the eye is such a small organ. Okay, so you completed registrar time. You're now in private practice. So tell us about the adventure of setting out to start your own practice or be involved in a practice with others, associates in a practice. How did that journey unfold for you?
What an adventure. And there are people with way better adventures. Not that it's a competition, but it's just so it is so amazing. I sometimes look back and I go, what was I thinking? What if it didn't work?
Yeah.
What if no one came to see me? What if? But once again, there are so many things, and I think COVID has taught a lot of us that there are actually so many things that we have no control over. And so whatever your belief is about the bigger picture, I am just extremely grateful. So many things just fell in place. And I remember in my final year, just after my exams, I was just feeling so lost. And I decided, well, I know I enjoy anterior segment surgery, and there's an anterior segment conference every year called SASCRIS, every second year. And I went there just to, you stay in touch with the knowledge, and you see some international speakers and so on and so forth. And I ran into a colleague that had finished specializing 5 years before me. And he said, what are your plans? And I said, well, actually, I'm desperately looking. He's like, well, let's have a chat after SASCRIS when we get back to Joburg. And they just had a room available and said, well, you can come and pay rent with us. Then if you join us, then there's less rent, and we use each other's equipment, and you just have to set up your own room. And then I did.
So it was through that connection you got an opportunity.
It was literally just over a beer after one evening at one of the conferences. And so one really has to have that sense, and it's difficult, looking back. You feel, your knowledge base is good, but you don't have all the experience, and everyone's read these days about things like imposter syndrome and social anxiety, and there's things out there that are ridiculously common. So now you have to go and put yourself out there, and you have to compete with all the narcissists that have no issues putting themselves out there, and it's just like, where do I fit into the system? But when you reach that level, and even when you finish with med school, you've worked hard, or at least you should have worked hard, and you have a very special gift and skill set and experience behind your back, and you just have to own it and put it to work. And there are leaps of faith, and take them, and don't expect life to give you anything for free. When these things do happen, grab them and make the absolute most of them, and give recognition where it's due. Like that's an opportunity where, sure, you can say I went to the conference and I had these conversations. I could have just sat in my hotel room, but at the same time, I'm very, very, very grateful and fortunate for the opportunities that have come my way. And you obviously, during your student years and your reg time, people get to see your work ethic. They get to see how you treat patients, how you treat your colleagues, how you treat authority when no one's watching, and that builds your reputation long before you're out there and getting your reputation on Google or social media or whatever.
Very good.
Do those things, be consistently used, so that when the time comes to ask for that position, then you have actually got a reputation, and you've met one or two representatives from the companies, and they've seen an interest and they've seen your knowledge, and you can't really. I have a colleague that always used to say, fake it till you make it, but it's actually because she was it. She just had to tick all the boxes and jump through the hoops and write all the exams. She wasn't actually faking it. She was already that individual. She just had to go through the process. But obviously what she meant was just keep going. And if you're consistent in your effort and your work ethic and in the way that you approach patients, then you'll find your place, because there's need for such people in the system. People that care, people that can manage their practices and their finances well, people that are good with staff, people that respect their colleagues, etc., etc. Just be that person, and the opportunities will open up. The adventure will continue.
Yeah. And at what point did you decide that you're going to go into private? Were you ever considering to stay within the public sector, maybe take up a consultant role? Did that ever become an opportunity that you had to think about?
I did actually consider that. I really enjoyed teaching. It is still the thing that I miss most. And when colleagues, optometrists, or slightly younger ophthalmologists, or registrars and so forth, ask if they can come to theatre with me or something like that, I love that, because you get to share something that you just absolutely enjoy. And fair enough, there are people that don't, and like I said, there are diverse personalities. But in the state sector, you obviously just teach so much, and it's tremendously rewarding to see the light go on, for people as you go through the system. You just see people grow, and you see people go past you and get better than you. And it's really, really rewarding, and those are then the colleagues that you look out for, and when you need help with stuff, because we all need help. So the thing that made me choose was the fact that unfortunately doing both well is, I think, extremely difficult. And there are people that do it, but I think, based on your financial setting and how much reserves you have and how much people you have depending on you, the public sector is very strict in terms of how much time you can spend in private practice. And I wanted to manage that well, manage that ethically, not take time away from my state clinics to go and spend more time in private practice. Sure. So that tension became too big for me, and the state sector obviously puts a cap on you in terms of the time you spend, how much you can earn, what you can do in terms of resource availability, etc. So at some point I had to just go, well, something's gonna give, and private sector had more freedom in terms of doing things that I hadn't yet done before, change flexibility with working hours, which would allow me then to cover my overheads in private practice, because I was literally paying my private practice overheads with my public sector salary,
sure,
while still providing, adding to the family income and so forth. So private practice was much more risky, because then you start from scratch, but it has less of a ceiling, so you can then work towards surpassing your potential. But if you're an academic and teaching is your primary passion, then it's very hard to get that outside of the state sector, and I still miss it.
Yeah. Okay, so take us through a day or maybe a week in the life of Dr. Johann Lamprecht. So how much of your time would be spent in theatre? When would you be in clinic? How much time are you in your rooms? And what are your working hours like?
So sitting here answering these questions, I find myself getting sidetracked the whole time, because there's so many little details, and I think to myself, oh my goodness, a whole week. I don't know where this conversation is going to end. But let me try and keep it simple. My theatre list is on Monday afternoons.
Okay.
So ophthalmology is a surgical speciality, and I see patients on Monday morning. Often it's patients that I want to do a quick check before taking them to theatre, but whoever else gets that gap in my calendar. And then I head off just before lunch to theatre, and then I operate the whole of Monday afternoon, which is really good because then you have the whole rest of the week to deal with post-operative issues. And you might think, well, you shouldn't have many post-operative issues, but one of the things that I enjoy is specifically complex anterior segment cases. So people that have had previous trauma and iris tears and traumatic glaucoma and people with dislocated lenses. And so those patients are quite unpredictable in their first few days post-operatively, to ensure that they are stable, that their eye pressures are at the right level, and there's just a greater degree of variability with certain surgeries than with others. So that's why it's nice to have the rest of the week open. So the rest of the week, Tuesday morning I do all my post-ops, and then I just consult for the rest of the week.
Oh, wow.
But I often have to see these patients again on a Wednesday or a Friday before the weekend to make sure that these more tricky cases are stable. And it's basically a matter of, come in when I want to come in and leave when I want to leave. It's nice having your own practice, but one obviously wants to optimize your time,
Sure.
So you get up in the morning and go train, and then you come home and you do the school run, and it's all chaos and toddlers screaming and usually flying all over the place, and then you make it to work and you're like and then you start, and then the day just flies by,
Yes.
And it's just it can be tiring because there's this relentless decision making, and like I said, you deal with the anxiety and the complexities, and at the end of the day you get there and you're tired, you go home. And
so an overly simplistic view of physician encounters with patients versus surgical is that the physician will have a long patient encounter and see the patient repeatedly in clinic and manage them over a long period of time. And again, as I said, this is a simplification, and it's a myth that the surgeon will only see the patient maybe once or twice before surgery, see them in theatre maybe once after, and then goodbye, live the rest of your life in health. That's not really true, particularly not true of ophthalmology,
Yes.
because there'll be follow-ups
Yes.
over months and years to come. So how many of your patients are you seeing on a regular basis? Or maybe I could reframe the question to say, how regularly are you seeing most of your patients?
So it's very individualized. I see
That's a diplomatic answer.
I see quite a bit of it's fascinating how individualized it has become, really, just the amount of information we get from the scans and so forth. But things like glaucoma and macular degeneration, and those are lifelong conditions. So then you see, based on how stable they are, maybe once a year, or maybe once in 3 months. People with active disease, you often see even more than once a week, or like your exudative macular degenerations, you see them at least once a month until you've stopped their exudation and their bleeding, and then you start extending the interval. So it's absolutely, there's a lot of chronic conditions, and I have a lot of patients that I've seen. Like I have one patient that was one of my first patients, got a vein occlusion, and he's got macular edema. And he got steroids in his eyes, he developed a cataract, he had cataract surgery, and shortly afterwards had a retinal detachment.
Sure.
And which is one of the processes that gets accelerated by cataract surgery or repeated injections. So then you have to deal with that, and then then you got glaucoma from his steroids and post-retinal surgery. So you go through this whole journey where you might see a patient once for a simple cataract. I shouldn't.
There's no such thing as a simple cataract.
What in your mind, or in the medical aid's mind, is a simple cataract? But and then they come back and they had an artery occlusion, or they developed diabetes, or they get a retinal detachment, or they had trauma. Just unexpected trauma, and the iris and the lens is gone, and now you have to start from scratch. And it's just. There's no, you don't know who you're going to see again, even if it was a quick finish and class.
And you said your theatre list is Monday, and
Yes.
that leaves 4 days of the rest of the working week where you are not in theatre.
Yes.
So you're not. It's not really a theatre-heavy surgical discipline.
No, so the dynamics change. Most ophthalmologists. So I've only been in practice now for 6 years, and there have been some pretty tough economic times, and it's been 2 years of COVID. So it's hard to say exactly where on the curve I am, and also starting by yourself, setting up a room and just working off overflow, as opposed to a very busy practice where you now take over some guy's practice and there's thousands of files and you have to there's different growth rates for different practices.
Sure.
So my surgical capacity is definitely not full yet. But like I said, you might get people that become medical ophthalmologists or neuro-ophthalmologists. They don't do surgery at all.
Yes.
So most ophthalmologists would probably have a full day's list or about a day and a half of theatre time. If they're at sort of maximal surgical capacity and they get lots of referrals for specific conditions that are surgical conditions. So, and obviously if I see emergencies, then I often do take them to theatre Wednesday, Thursday, Friday.
Sure.
So,
are you ever on call as an on-call
Yes.
ophthalmologist? Okay.
Yes, so the hospital that I work at, we just have a sort of a 2 weeks at a time. One person covers the whole of that hospital. All the calls that hospital gets forwarded to me, and sometimes it's absolutely madness, which is another myth about ophthalmology, is that it's really the chilled life. I guess when you're in private...
There are eye emergencies that require you to come out late at night.
Yeah, although I don't know who follows Dr. Glaucomflecken, but he has some very interesting videos about that, which are so funny. And yes, we do, compared to, say, vascular surgeons and trauma surgeons, it's not that crazy, but we do have emergencies. And I often, when my friends would see me early on when I was specializing, they would say, "Hey man, how's it going? Did you save anyone's eye today?" I'm like, "No, dry eyes and a little of blepharitis." But there are those conditions. I once got a call on Christmas Day to go to a hospital in the southeast, like Ekurhuleni, and it was a patient that had sinus surgery, and she developed a retrobulbar hematoma.
Wow. And
she literally had no light perception in that eye, and I had to do a lateral canthotomy and canthelysis, and the next day her vision had returned to 6/9, and a week later she was 20/20 again.
Wow.
So that's the kind of
very
thing
rewarding. Hey.
So that's amazing. So there are these cases, and by the fact that I remember that one, it tells you there's not that many. But you get doctors that work in like Garden City, Netcare, or the trauma centers, Mill Park, etc., where you see a lot of much more urgent stuff, or you get Stephen Johnson cases referred to you from ICU.
Sure.
Those are urgent things. So it depends on where you are and your scope of practice. There are ophthalmologists that are really busy and work late into the night, and there are ones that have heavy theatre lists or that almost only operate and see pre-ops and post-ops, and then there are ones that are basically medical ophthalmologists that don't really go to theatre often. So even within ophthalmology, there's a wide scope for different personalities and different skill sets. I think it's a big leap to get that far and then still figure out, but we're all, I guess, constantly figuring out what is it that we're really, really good at and what we really enjoy.
Sure. So what is the training in South Africa? How does that compare internationally? Are our ophthalmologists competent by international standards, or are we restricted in any way, maybe in terms of the equipment we have, or the cost of getting equipment? You mentioned the exchange rate. How do we compare?
So this is obviously I'm not high up in academic faculties, and I don't compare curricula from around the world, but I think ophthalmologists in South Africa are extremely well trained. Once again, it's what you make of it. You can sort of get through the system in a less ideal way, but it's not that easy. The exams are strenuous, and your knowledge is tested wide. So hashtag don't be that guy. Just make the most of it, because our training's excellent. We almost universally have more surgical experience than in other countries, especially the European and the Far West. like I've been to quite a few international courses, especially in Switzerland, and one in Greece, and you meet people from all over Europe, and they're just really in awe of the amount of surgery that we've done, and all countries have financial constraints, and depending on whether it's a socialist healthcare system or very much bureaucracy in terms of what you can and can't use, and getting approval from all the funders, and even in capitalist economies, South Africa has this weird mixture. But even in the US, there's the exact same issues we face with getting funding approved for medications and so forth. So there are always the fights about the money, and it's what was the question?
No, so I think you've already answered it fantastically well. That we do compare well. You're not gonna suffer for having a degree in South Africa.
Absolutely not. Not in terms of ophthalmology. Like, honestly, we have had over the past century numerous pioneers in various subspecialties in ophthalmology, world-renowned speakers, or at least individuals, and also, unfortunately, with the amount of people that immigrate, there are a lot of incredible South African ophthalmologists that trained here and eventually left and went overseas, and are hugely successful in their practices, whether it be in somewhere in the UK or Canada or Australia, New Zealand, etc. So really guys that come from here with a tremendous foundation of ophthalmology, and then go out there and make it work anywhere in the world. So,
amazing. So if you cast your mind back to when you were a junior doctor, and you obviously plied your trade here in Joburg and then at the Telspruit, what were some of the lessons that you learned that you wish to pass on to junior doctors, so that we can be spared the pain of learning the similar lessons?
Well, one of the first things that immediately come to mind is don't burn your bridges. Just don't burn your bridges. And the second thing is just, we all have such big knowledge gaps, all of us, and don't try and hide it. Be open about it, because the more open you are about your knowledge gap, the quicker you learn. I think we have this thing in human nature where you always want to put your best foot forward and pretend like you know everything. But I find that some of my most senior colleagues and respected colleagues sometimes ask the most, simple but then the most profound questions, and you realize why. I felt too dumb to ask that, and here the boss is asking that question in front of everyone, because he doesn't care anymore that people, and he knows the answer actually.
There's no pageantry of trying to earn a award mark,
He or she is humble enough to ask that question for the benefit of everyone else, and often asking a question is for the benefit of more than just yourself. But getting back to the don't burn your bridges, there was this funny, in my internship I did anesthetics and orthopedics directly after one another. And there's always a bit of a tension between anesthetics and orthopedics, because orthopedics is surgical, very system focused, and lots of emergencies, and then the anaesthetist is left, sorting out all the other the comorbidities,
other considerations before that patient can even go to theatre.
Exactly, and it's surgery with blood loss and all of that. So, and I was in the one speciality where you were like constantly fighting with the anaesthetist to just get your case on the table, and then immediately went over to the other one and working with the very people that I was fighting with to tell these orthopods, like, no, the patient's not ready for theatre. It was so funny, that immediate tension between the two. And, I could have definitely managed both residencies better. And then in terms of the knowledge gap, our head of department in my final year, I said, Prof, like the more I study, the more I realize I don't know. And this is in my final year before exam. And he said with this big smile on his face, he says, yes. And on the day of the exam, you realize you know nothing at all. And I was like,
thanks for the reassurance.
That's encouraging. But it was encouraging because we feel like that.
Yes.
You actually, the more you know, the more you realize you don't know. And you have to just handle that tension, but it's actually a good place to be. The more you realize you don't know everything, the more open you are to learning. And there's absolutely no shame in asking the dumb question, because someone else, including me, also wanted to ask it, and felt too blind doing so.
Yeah.
So, yeah, that's
One of
those two.
One of the best parts of being an intern, I think, is reading for enjoyment, not to pass an exam. Like, I've actually really enjoyed reading some notes and absorbing stuff in my own time, not because I have a couple of weeks to cram for an exam. How do you go about with your continuing education as an ophthalmologist? What are you reading to stay up to date? How are you continuing to grow now that you've qualified and you've got your own private practice? What fuels you to keep on reading and learning and growing?
So I think the answer is seasonal, because like right now I have a toddler at home and my wife is extremely busy. So we have to find that balance. And I just do not have the luxury of reading anything for enjoyment. Not even the back of the newspaper. You
Even prioritizing your WhatsApps. Do I need to read this right now?
Exactly. It's I just don't have that time.
Yeah.
But you can't fall behind, especially in a technology-driven field like ophthalmology. Things are just changing so quickly.
Are there any resources you can recommend or suggest that if you had the time you would tap into?
Two things that, I always have long answers for short questions, but two things. The one is your conferences. I was not good enough at making time for conferences as a junior doctor, and I'm now and it's hard because you're always on call, you always have to cover, and the senior guys go, but when you do get a gap, those conferences are great because, like you heard, it also opened up a connection for me to start practice, and you just get to see your colleagues in a little bit different environment. You're not constantly one being asked questions. You can sit back and there's a speaker and you hear them present, and you sometimes see their complications, and everyone's asking them the hard questions, and you get to see other people's mistakes, and you go, oh my word, I thought I'm the only one that did that, and it's a different environment to learn. Plus then in the evenings you have the welcoming event, and you've got the
a bit of social vibes.
Saturday night dinner, and you just get to hang out and talk to people and meet people, and that's really a different style of learning. And then the other thing is presentations. There are various platforms that allow for you to actually give talks to junior doctors, to other like associate, like for us we have optometry, for instance, doing lectures, because everyone needs CPD points. So it's quite intimidating to talk to other ophthalmologists, but presenting at a conference and doing that, even if it's just like a well read up case report, you learn so much by doing that. I always learn so much when I'm preparing a talk to give to someone else. I'm the primary beneficiary of that presentation. So those are two ways that are a little bit different than just like sitting and reading or going through the usual training program. Is these slightly more social events, and then also where you then start giving back and you teach. Like I said, I miss the teaching, so that's probably why it's one of the primary ways for me. But it really, again, you get to present on cases that you enjoyed or that were particularly challenging, and then your colleagues go, oh wow, yeah, I had a case like that, what did you do? Or the optometrist might see, oh well, this is your scope of practice and your interest, and then a patient walks into an optometry practice and they know this guy likes treating this condition, or he's dealt with difficult cases in this field. And that's how the whole social system fits together, and we stay connected and help each other.
Yes. So if you were to look into your crystal ball of ophthalmology now and cast your vision to the next 10, maybe even 20 years into the future, what do you see in the field of ophthalmology? What are the new developments? What's the latest cutting edge? And where's the sub-discipline or the sub-spec going?
Wow. Which one of those questions? No, so I being in private practice, there is an awareness in the future of things, of the rest of the environment, political environment, the financial environment, and ophthalmology is marching forward with just incredible utilization of technology, and augmented reality is just going to play a bigger and bigger and bigger role in everything from real life, superimposition of specific like incisional angles and positioning of lenses and refraction, used real time in surgery. We already have that. It's just not that widely available. Where you're putting in a lens and the microscope in real time refracts the patient, tells you whether your astigmatism axis is aligned and is your lens the correct strength, and those things are in use and it's available.
Is there an increasing reliance on computers and digital technologies and AI and things like that?
So reliance and usage, you always get the guys at the front of the curve that really push the envelope of what a specific technology can do, and then the guys that are behind and are not using things everyone's using, and then there's that middle of the bell curve. And technology, especially I think in ophthalmology, but I guess everywhere, it's not just a gimmick. The information we get is incredible, and constantly the subspecialty communities are having to update protocols and classifications, and you bring into that the genotype of the whole thing, and you got things with a similar phenotype but a completely different genotype, or different phenotypes but it's actually the same disease genetically, and the technology allows us to just refine this. And unfortunately we don't always have better treatments, but even there, and the molecules that we can design, and in specific, like receptor specific molecules, specifically your biologics and so forth.
Sure.
The technology, it's only going to be pushed in that direction. And I guess you look at the R&D costs, and there's also a need for companies to get back some of that expenditure on R&D. So is the latest newest thing always the best thing, or is it just being marketed? There's that balance, and we need to, patients often come in here and they're like, oh wow, the technology is amazing, and then I just hold in front of them like a little 78 diopter lens, which is exactly the same as the one they used 100 years ago.
Sure.
The newest, latest thing is not always the best, but it forms an integral part of what we do.
Yeah.
And patients are also engaging with technology more. So I mentioned augmented reality. There are spectacle stores that no longer have to keep stock of frames. You walk into an AR room where you can fit all the different frames, and then once you're happy with the one that you like, then you order your frame. It was all augmented reality. So the utilization and integration of technology in the everyday things that we do is a huge part of ophthalmology as well, and that's only going to become more and more common. And like I said, there's then how do you make it financially feasible and accessible and so forth, and this is where disruptive technologies come in, and seeing how do you make it cheaper and more available and so forth.
But what I heard you say is that this is a field that's growing. This is a field that is very open to technology and definitely has a place for these new technologies and
Absolutely.
new devices and stuff, even though it's grounded in things from 100 years ago or even further. It is also, as you said earlier, it's a field full of microsurgery, really, really intricate details. I mean, I've seen you work on the anterior segment, and it's your depth of your entire surgical field is less than 1 centimeter that you're working in. It's quite amazing. So thank you so much for giving us some insight into ophthalmology. I think the junior doctors and medical students and even the consultants from other disciplines who tune into this podcast have learned quite a lot about what our ophthalmology colleagues are studying, what they're doing. One final thought, if I could push you for just a closing message or closing thoughts to anyone listening to this podcast, if you want to leave an impression on them about ophthalmology, just in general as a speciality, what would you have to say?
An impression about ophthalmology. Wow, it's like any speciality. It's a field that requires both the passion, the drive, sort of the feel of it, as well as just the grafting, the day in, the day out, the doing the stuff that you don't. And that's not specific to ophthalmology, but I do sometimes think there's this impression out there that ophthalmology is the easy life. If you're going to be really good at what you do, and your patients deserve you to be the best that you can be, if you have specific opportunities in life that allowed you to get to med school and to specialize, and so many things have to fall in place for that, and a lot of it is also your hard work. So like, just make the most of it. Make the most of it. Don't forget to have fun and enjoy it, and don't take yourself too seriously. But make the most of it, because the better I get at stuff, the more I enjoy it. And the more I enjoy my time with my patients, and my patients their time with me, the more freely you can discuss things, the more honest you can be about the difficulties of complex cases and so forth. So, it's a little bit cliche, be the best that you can be, but it takes a lot day in and day out to be the best that you can be. And then on the flip side is the issue of burnout. Burnout is very real. Anxiety among doctors, depression, substance abuse, etc. You need to know how to rest. And if you're not going to rest well, you're going to sort of rest every day and just be sluggish and not be the best that you can be. So there's the time to work hard and really graft and pull your weight. And then there are times to wind down and relax, maintain your friendships, work hard on your relationships, and not neglect those things, because it's also required in order for you to then go back and be the best that you can be.
You've almost prompted a whole new podcast episode now. We're thinking intentionally about rest rather than just saying, oh, okay, it's a free time, I can just sit down. But I think we'll end there for now. Thank you so much for your time, Dr. Joe. It was an absolute pleasure to have you on the podcast. Thank you very much for sacrificing.
And if I said anything really silly, please forgive me. Out there, people, universe.
It was all great. It was all gold. Thank you so much.
I hope you enjoyed this week's episode. If you know of a specialist consultant or a senior registrar in a specialty that you want featured on the Dr. Coffee podcast, then please get in touch. The podcast's email address is drcoffeeza@gmail.com. That's drcoffeeza with no punctuation marks. We're also on YouTube as well as Instagram, where you can follow us with the username @drcoffeeza. If you've got anything else on your mind, such as a request for additional topics, further information on how to engage with our guests, feedback on the show, or anything else, please get in touch. We'd love to hear from you. The Dr. Coffee podcast is brand new and brewed each week with you in mind. If you enjoyed this episode, please consider sharing it with the medical students or junior doctor in your world who you think would benefit and enjoy the content. Bye for now.